All right, guys, we are going to go ahead and start. So this is a quick chapter. This is going to be processing the digital image. Okay, so yesterday we talked about how we acquire images, how that process looks. Now we're going to talk about what happens with our um, detector and all the captured X-rays within the computerized system. And so when we look at things, guys, our images come from the detectors, right? The detector elements are housed on those, DR detectors or receptors that we see. Now, when we talk about these images that are held on there, they're termed raw data. Okay, the image is captured as raw data. The raw data is what comes about that can be processed by the computer. And so when we talk about processing, processing can occur a number of ways. Okay, and there's two that we primarily deal with. And so pre-processing and post-processing are the two processing avenues that we see. And so one of them we're really familiar with, right? You should have learned about post-processing at some point, and you probably use post-processing on a daily basis, right? Um, when we talk about pre-processing, think about like the behind the scenes, right? These are things that are happening without us even knowing. And in some cases, these happen in seconds, milliseconds, even. Okay, and so we're going to talk about those things. But first, we have to note that no matter what, an analog to digital converter is needed. We're trying to convert our X-rays into a digital signal. And so that's what the analog to digital converter does for us. It will establish that, and then we'll get a digital signal that will be displayed for us. And so when we look at things, there are two steps in analog to digital conversion: sampling and quantification. And so in sampling, what happens? Sampling basically is taking a representation of what is on the detector and creating an image based on that. And so when we look at things, what we're looking at is the ADC, or the analog to digital converter, is going to perform our sampling. It's going to gather the information that allows for our image to be digitized. Now, there's some parameters that have to be established, or some guidelines that we have to follow with sampling. And those guidelines involve what's called Nyquist theorem. And so Nyquist theorem is going to tell us, hey, when you sample a signal, we have to sample at least twice the frequency of the input signal. Okay, so essentially, we need to make sure we're having at least or twice the amount of pixels to be sampled. And so whenever we do that, we're allowing our system to be much more accurate to what our actual image is capturing. Okay. And so, again, in digital imaging, twice the amount of pixels have to be sampled. If we don't have enough pixel sampling, lack of spatial resolution occurs. And so when we look at these images, A showcases proper sampling. How we can know that there's proper sampling is imagine each wave, okay, is what we need to sample. Well, in this diagram, here's where it's sampled. 1, 2, 1, 2, 1, 2, right? So it's sampled twice. Now, when we go here, look at this waveform, okay? Sampled once. This waveform, sampled once. And so we're not getting the adequate sampling that we need. And so that can, again, cause our spatial resolution to be degraded. When the spatial frequency is greater than the Nyquist theorem, what we end up seeing is a artifact. It's called aliasing. And so this aliasing effect looks like this. Okay, it results in a moire effect is the name. Essentially, it looks similar to what grid lines would look like, right? If you've seen those grid lines, that's kind of what we see, right? Just these lines in place. Now, quantification. So after we sample, we're assigning each of the sampled items what's called a value, right? A given value. And so that value will translate to a shade of gray. And so that's what you're seeing here. Okay. So we're sampling these pixels. We're going to quantify them, right? Quantify meaning, give it a number. So we're going to give it a number. Every number that we use will translate to a shade of gray. And so that's where we end up with C. So we sample. Here's the quantification where we're giving a number to those values. And then the final stage is going to be those numbers converting to a shade of gray. And those shades of gray are based on that grayscale bit depth that we've talked about previously. Now, histograms. Histograms are essentially the data that are formed within your collimated area. Okay. So while we're giving numbers and assigning numbers to our image, a histogram is being formed that represents all the shades that are being taken within our collimated area. And so, all values are being measured. We're seeing one end of the graph where all the black shades would be represented. The other end would be where the, whiter shades would be, right? And so we're taking this information because our computer, again, this is happening within seconds in our computer, is doing what's called a histogram analysis. And so a histogram analysis identifies all the values of interest. So all the things that are going to be considered values of interest are identified. And then our histogram that we took is going to be compared to a histogram stored on the computer. That histogram is called a reference histogram. And we'll talk about that more in a bit. But there's some issues with digitizing images, right? We have to make sure we are utilizing the machinery properly. So if you don't know how to use DR, there can be some limitations, right? And so these are what we're seeing that can occur. So this image here, we can't establish a collimated border, so it looks completely whited out here. And we know that we can window width and window level to get probably our image here, right? Essentially, this is what we should have. We should have a collimated border on all four sides and the part centered. It's very important to have those things because if not, your reference histogram will not transfer values properly, and you'll get an image that has the wrong brightness and contrast. When we talk about other issues, this occurs in CR a lot more, but I've seen it in DR. So say, for example, you have a multiple study, right? You're doing like a chest and a wrist, or a, wrist and a femur. For whatever odd reason, you're going to do those two images. The wrist and the femur may have different algorithms attached to it. So when you select wrist AP versus femur AP, those have different filters or algorithms within it. Those are the reference histograms. Well, so by selecting wrist AP, you are loading up a reference histogram for a wrist AP to be compared to your wrist AP. Now, if you were to shoot a wrist AP under the femur AP window, right, or algorithm, well, our wrist AP that we took is now going to be compared to a femur AP that's stored in the computer. And so those values may not translate the way we want to. All right. And so that can cause issues. And that's what's showcasing here. A chest x-ray is ran here. A chest x-ray is ran here. The bottom one, a pediatric knee filter is ran. And so you can notice the difference, right? And so that's why it's important that we select the proper values when we are, creating our images. The lookup table is essentially that process where that reference histogram is compared to our histogram. The reason it's important is pretty much every system that you use now with DR has this feature where it's going to alter the values. The biggest one I can say is if you work on GE, I know this 100%, you can see the raw data images. There is a tab within a GE digital system where you can see what the raw data looks like before the lookup table is applied and you see the image that you are used to that looks like this. Okay. Essentially, you're going to have the reference histogram, the lookup table, which is this image here, compared to a perfect chest x-ray in the computer. And then what happens is that reference histogram will now then alter the values it captured. So this is showcasing that lookup table being applied so that now we get an image that looks like this. Okay. Another name for this lookup table is grayscale processing. That's what's happening. We are editing the grayscale. All right. When we look here, what we see is we are seeing just that process happening. Okay. We're seeing our lookup table being applied to this image here. Notice how you can see the line here that's indicating, hey, you need to alter these values to come out here. These values come out to this shade. Here, these values to come in, right? And then that's why you can see a better image in regard to the window width and window level, the contrast, and the viewing of the image. Now, pre-processing. Pre-processing, again, is the stuff that occurs that we don't see. It happens in the computer before we see it on our image. Basically, those algorithms are formed, raw data is determined from that histogram, and then certain things happen. Detector defects are removed, noise corrections applied. And so when we say defective dead pixel corrections, when you consider a matrix within a detector, right? There may be 2000 by 2000. And so, if I were to type 2000 by 2000, that's like 4,000 pixels within that particular exam, right? In that particular detector. Who's not to say one small pixel can be damaged, right? Does that mean that, okay, one of those 4 million pixels is damaged, we need to replace this entire detector? No, right? That doesn't make sense. If only one of the pixels is damaged out of 4 million, then we should be able to have some sort of workaround. And this is the correction aspect that occurs. It's a defective dead pixel correction. Essentially, if there's a dead pixel, that dead pixel is kind of seen as this, whitened space here. What will happen is the machinery will average all the areas around it and then assign a value, right? And so that's what happens. If we were to average all the numbers here, we would get a value of 299, and then this is the shade of gray associated with the number 299. Okay? That software correction is built into the system to allow for us to identify and isolate those dead pixels, right? So that, there's not just a white space where something shouldn't be. Okay? It's essentially also called signal interpolation, right? Interpolation basically means we're going to guess, right? We're going to make an educated guess, but we're going to guess what that value is based on what surrounds it. Flat fielding is another processing correction that occurs. Essentially, with flat fielding, we're imaging the anode heel effect here, right, in image A. With image B, it's flat fielded and it showcases uniformity. Okay, that's what you're seeing here. So instead of all these areas that showcase the anode heel effect, in image B, the flat fielding correction kind of minimizes and uniforms the entire plate. And so that's why, back in the day, anode heel effect would be a major concern that people would have to account for. Nowadays, in digital, you don't need to because of this correction filter. Another thing we're seeing here, we are seeing automatic rescaling. Automatic rescaling is seen here where if you use more or less exposure than you need, the system will correct itself. The system actually corrects itself anywhere from negative 50% exposure to 500% overexposure. And so that's the wide array that we see. Okay. The problems occur is when you don't use enough exposure, when you go more than 50% less than what you need, that's when quantum noise occurs. Or whenever you use over 500% overexposure, that's when saturation occurs and you start to lose contrast at the edges. There's no substitute for appropriate technique, right? And so the term dose creep is found. Essentially, what's been happening is you may see this occur in your clinical environment where a technologist may use a certain dose to say, hey, I'm going to use this dose. I rather use a higher dose on this patient to know I get the right image. Because if a machine can correct up to 500% overexposure, some technologists think, hey, that's free reign to just blast these patients, right? Because if I choose the wrong technique and it's not enough, I'm going to have to repeat the image, right? So they think overexposing is better, right? Which is not. That's not what we should do. That doesn't replace using the proper technique that we should know and based on what we've learned, right? As far as a technologist, as far as our clinic rotations. And you can see it even occur in these images. A is what happens in film. Notice how if you're completely underexposed, you can't see your image. If you're starting to get overexposed, you start to lose contrast at the edges. With B, this is in digital. So in digital, look what happens. 2.5 looks good. 40 MAS looks good. 80 MAS looks good, right? And so here's our adequate value, right? Like maybe 70 at 10 or maybe even 70 at 5 would be the best values to use for the patient. But if you use 80 at 70, hey, it looks like almost the same, right? And so that dose creep does see itself being found. When we talk about our spatial frequency filtering, what you need to know is spatial resolution is limited by the pixel size, obviously, because we have to image something that is the size of the pixel. If it's not the size of the pixel, it will not be recorded. And so high spatial frequency just basically equates to us imaging small objects. Imaging small objects, high spatial frequency. It's more difficult to image. So think about, those microcalcifications, those really small fracture lines in some of the bony areas that we see. And so difficult to image. Now with low spatial frequency, these are imaging large objects. They're easier to image. And so think about larger portions. We're thinking about liver, kidneys, brain, those sort of things that are really large and can be imaged properly. And essentially, there's also something that occurs that we can do, which is called spatial frequency filtering. And so this filters and processes the image itself, right? We can control the sharpness. And so the first one is edge enhancement. This is high pass filtering. It improves the visibility of small, high contrast areas. Edge enhancement occurs when fewer signals in the neighborhood are included in the signal and averaged. Okay. The smaller the neighborhood, the greater the enhancement. So essentially, what's happening is we're looking at the edges of the image. It is very, very important. Look at the edges of an image, and then you can kind of see the sharpness. And so that's what edge enhancement does. It makes those edges more sharp. With smoothing, this is low pass filtering. It's intentionally blurring an image. So notice how image A is grainy. There's not enough technique used. You can see all the salt and peppery effect. Well, smoothing is going to average the pixel frequencies surrounding each other to remove that high frequency noise. And so if you look at B, it looks like all of those salt and peppery effects are gone. But what we're seeing here is we are seeing it looks a little bit like there's motion. Okay. And so that's the trade-off. All right. Final section here, the post-processing section. So when we talk about post-processing, this is done by the technologist after the image is displayed on the viewing monitor. So essentially, when we play with these things, we're preparing the image for viewing, right? And so we want to do that. Even the radiologist has some option to post-process at their workstation. Here's some of the tasks that you can do under post-processing, and we're going to talk about a few of them here. Yeah, this is the same image. Annotation. So annotation is essentially found on pretty much every digital system now. You're able to annotate, left or right side marker, even though you shouldn't be able to. You're able to place AP on there, PA, portable. You can even text to type something on here. Okay, that's annotation. With window level and window width. So window level, as window level increases, image becomes darker. As window level decreases, image becomes lighter. The window level is adjusting the brightness of that particular image. Okay, that's what it's doing. And then what we're looking at as far as window width is adjusting the contrast. We're saying how many shades of gray should be made available for us to use. And so as the window width narrows, contrast increases, as you can see here. As window width widens, contrast decreases. Okay. And so that's what you're seeing here. Inversion, black and white reversal. Okay. So once you guys start learning fluoro, you're going to start to see inversion regularly. Fluoro operates under inversion. But this is what you can do. Here is our hand x-ray taken as a regular radiograph. You can press a post-processing feature to invert it, and it'll look like this, where bone is black. It's useful to see a lot of things. When I was a technologist and would work on portables, and we would have to take these, chest x-rays, sometimes it was very close at the edges. And what we would do is use black and white reversal to see, hey, did we get that costophrenic angle or not, right? It's also used a lot by physicians and mid-level providers who may, after we take an X-ray of a breathing tube or a line being placed, want to check that location of that area. So you might see that also. Equalization, honestly, I've never seen this post-processing technique used. You probably shouldn't worry too much about it, but essentially underexposed areas are made darker, overexposed areas made lighter. And so you can kind of see where that occurs here, and you're able to see more in here where the lightened area is removed. But I wouldn't worry too much about equalization. I haven't seen it too much. Subtraction, it removes certain processes. So that's what you're seeing here. When you look at it, it removes some of the superimposed structures. Image A showcases the removal of bone. Image B, the soft tissue is removed. Okay. Cropping or masking. So this is something you shouldn't do, right? Regularly. The only reason you are to use this is to remove this whitened area. You see how there's white areas here because the collimation isn't identified. And then now when we use cropping or masking, it looks like this. That is what you're supposed to use it for. You're not supposed to use it to collimate after the fact. That has no bearing. That does nothing. If you write that, um, as one of your answer choices for this document that you're about to submit, collimation, when it needs to be cropping, you you are gonna get a 0 for that particular answer choice. All right, because cropping and masking is not the same as collimation. Collimation is really affecting the patient. It makes them less adverse to radiation because less radiation is being introduced to the body when we collimate. Leaving a lumbar spine x-ray all the way open so it looks like an abdomen and then collimating afterwards does no purpose for your patient. Okay. So you don't want to do things like that. Image stitching. This is when multiple image receptors are used or multiple exposures are used. And then we stitch the image together to have a one larger piece. And that's what you're seeing here. It's common in scoliosis series, leg length studies. Those are common occurrences that you would see it. Those parts are longer than the average cassette size. And so we would see it. Magnification, you can do it one of two ways. You can right click and see a magnifying glass like you're seeing here, or the zoom in feature where you just do this, right? Either one can be used, and that's magnification. Region of interest is used sometimes. As you can see here, this image is taken. We establish a region of interest as so. And then what we can even do one step further is say to the computer, hey, we want to process our image only using what's within the region of interest. And that's what you can do here. And so notice how, here's our region of interest. Here's just that area. And then here's what happens when we tell the system, hey, we want to just find, and use this data versus all of the data that is found. Okay. As far as viewing the digital image, there's two types of monitors: cathode ray tubes, liquid crystal displays. For the most part, cathode ray tubes were the first iteration of what people viewed images on. Nowadays, pretty much every monitor you will see an image on is going to be a liquid crystal display or an LCD monitor. For the most part, I talked about the varying differences within these charts. You can see them here, the two differences. Here's even some more differences between the CRT, cathode ray tube monitors, and the liquid crystal displays. And again, CRT monitors are getting out of date. We're starting to see more liquid crystal displays take over. As far as viewing conditions are concerned, when we talk about viewing conditions, essentially radiologists view images with ambient lighting. So you notice how there's blue light back here. And so the reason that is because your eyes are attuned to do two different sets of environments, environment with light and that nighttime vision that is not as sharp as you're viewing during the day, right? And so this ambient lighting helps keep the radiologist's eyes, good to view images. He or she will not get any loss of their perception because they're reading in a completely dark room. So anytime if you get a chance to see a radiologist reading room, you can go in there. There's always going to be some light source that is in there so that their eyes aren't fully into that nighttime vision. As far as spatial resolution of the monitor spatial resolution has to match the image receptor. If not, we're going to lose quality. If we can record, 150 pixels on the detector, but we can only record 100 pixels on the monitor. Well, we're losing 50 pixels somewhere. Those 50 pixels are going to get averaged somewhere, and we lose resolution. So that's why it's always preferred that our resolution on our monitors have a large matrix, smaller pixels, and high resolution. When we talk about resolution of the monitors themselves can be the weak link of our chain. Okay, the reason being is depending on the type of monitor you have, it may not have the quality to succeed in the environment we need. Radiologist viewing monitors, they're 2K to 3K for digital images, 1 or 2K for cross-sectional images, and if they're reading mammos, their monitor may be a 4K monitor. The kind of monitor we have at a tech workstation is like a 1K monitor. And so, monitor quality is of importance. It's important that we understand that, our quality monitor that we are using is not the same as the radiologist. Their monitor is, 3-4 times as powerful as ours. So they can pick up on a lot more differences than we can. And so that's why, we have to be weary of those exposure index numbers and, those types of values that tell us what range is good for that system, because we may do a image that's outside of the indicated exposure values, and when we look at it, it looks fine, but then when we send it to the radiologist, he or she may toss it back because that's not of quality for their monitor type. And then as far as brightness and contrast, we're going to go over this again, but 300 to 500 candela per meter squared is measured at the monitor. Okay, there should be at least at the maximum, at least 250 at the maximum, and at least 100 at the minimum when measuring the light values. There are concerns with the monitors when we talk about how the monitor is shaped, right? We usually want the monitor to be flat, not those concave monitors that you may see or look cool, because that will affect the geometric properties of the 2D image that we're reading, right? So we want to be concerned on that. Veil glare is that area that we were talking about with the whitened space. This is called veil glare. So that's why we have cropping or masking, is to remove that veil glare area. And then, display noise can occur where there's some statistical fluctuations that occur with the processes within the computer. And so, something honestly we don't have to be too aware of. But we should know that, they occur within our systems. Okay. Other than that, that's the end of our lecture here, guys. We're going to be grading the assignments here shortly. I've been responding to the discussions today. Other than that, guys, we're at the halfway point, almost done with the first set of classes for this bridge program. Keep at it, keep pushing. I will see y'all next week. If you email me, let me know if you have any questions. You can always email me. I'm usually quick to respond to them. But other than that, guys, take care. Have a good one. Bye.